Good afternoon, everybody, and welcome to Medicine Grand Rounds. My name is Dr. Alan Taylor. I'm the chairman for cardiology, and it's my pleasure today to introduce our speaker, one of our great faculty members named Christy Kaiser. Christy is wonderful. Christy originates from the Midwest. She went to Washington University and then to Baylor College of Medicine for her medical degree. From there, she did her training initially at Duke in medicine and then came to us for her fellowship from 2012 to 2015. And then since 2015, we've been really fortunate and blessed to have her on our faculty. Christy's just a superb clinician. Her interests are clinical cardiology and imaging, really a fantastic clinician. Her research interests are educational focus, and she's an assistant professor with us in the clinical educator track. And she has a key role for us as our associate program director. And I can just tell you she's an amazing innovator from an educational standpoint. I'm always impressed with the number of projects that are innovating in the training program. Some examples, things such as simulations for education, and a boot camp that she established, which is really a novel way to onboard not just our fellows, but has really transformed initial fellow education across the entire region. All the regional programs come to us for their onboarding cardiology boot camp, and that's really thanks to Christy, and also to Brian Case, who is another, was a Georgetown resident and fellow with us. Christy is, one of the things I have to say about Christy though, is on her personal level, she's a champion. And here's what I mean by that. She's laughing. Everywhere Christy goes, something good happens, and there's a winning outcome. And so, and I didn't realize this, Christy, today till I looked and I remembered that you went to Baylor for medical school. And so it's particularly poignant this week. So she is a lifelong and diehard Kansas City Chiefs fan. And so she was excited when the Chiefs won the Super Bowl 2 years ago. But she's also very magnanimous, and she personally let Tampa Bay win this year, knowing Tom Brady was old, and she respects that. But she came to Washington, and the Caps and the Nats won, and she's a Baylor grad, and Duke won a national championship when she was there, and now Baylor won. So everywhere that Christy goes, good things happen. And so I think it bodes well for Georgetown's basketball team. Might take a while. It took a while for Baylor, but if Christy will bring it. But all kidding aside, Christy's a wonderful clinician and educator, and we're really grateful to have her today. She's going to bring us some insights from recent clinical trials, and nobody better to do it. Take it away, Christy.
Thank you. Yes, I agree. It was some delayed gratification for Baylor there, but I appreciate the vote of confidence. Okay, so we're basically going to talk about some of the trials from the past year that have been practice changing or potentially practice changing. And I want to try to also put those into the context of the bigger picture of what we already know about that topic from previous trials to try to come up with a cohesive story as to how we can use this trial or not to affect the management of our patients. So I want to weave in some questions, some patient questions to give some context here. So our first question is about transfusion for patients with ACS. So we have a few patients here. 80-year-old woman with post-op day number 1, OREF for hip fracture with a history of CABG and a hemoglobin of 6.8. And the question is, who would you transfuse? We also have a 60-year-old male admitted with a STEMI after PCI. His EF is 35% and his hemoglobin is 8.5. Or would you transfuse both patients? All right, so far we have most people that would transfuse the woman with chronic CAD with a hip fracture and a hemoglobin under 7. Most people that would not transfuse the STEMI patient with a hemoglobin of 8.5, but a little bit of discrepancy there. So let's go to the relevant trial then. So this gets us into the reality trial. This was just published in February on the effect of a restrictive versus liberal blood transfusion strategy on major cardiac events among patients with acute MI and anemia. And to set up the background for this, as most of you are familiar with, the major trial that came out that showed the safety of a restrictive transfusion strategy was the TRICK trial for critically ill patients using a threshold of 7 versus 9 to transfuse. And these were the results that they found at 30 days testing mortality. Overall, it was a neutral trial with this p-value of 0.1. But you can see that based off the curves, if anything, it appeared that perhaps a restrictive transfusion strategy led to decrease in mortality. They did enroll some patients with cardiac disease in this group. About 18% of patients enrolled had cardiac disease. And the results were similar in terms of mortality. Overall was slightly lower in the group with the hemoglobin of 7 threshold, but not statistically different. And they also looked at complications, not just death in this trial, including cardiac complications. And what they found was that if we look over here, we can see there was an absolute reduction of 8% in cardiac complications. And that was driven primarily by a decrease in MI and pulmonary edema of 2% and 5%. And that was statistically different. And so this kind of sets up the a little bit of the discrepancy in how transfusion should affect patients with cardiac disease and whether or not we should expect to see a benefit or a risk from that. So to review the physiology of this, the common sense would tell us that it would be instinctive that it's a good thing to give blood when you have someone who's anemic with cardiac disease to increase the oxygen delivery. And in fact, our instinct is that transfusion might be even more important for patients with cardiac disease than others, because the normal way that you would increase your oxygen delivery when the hemoglobin falls is to augment your heart rate and your stroke volume. And in fact, when they take healthy volunteers and they drop the hemoglobin, they can maintain that same oxygen delivery all the way down to a hemoglobin of about 6 just by better compensating. So if you take away that ability to compensate because you have a low EF for whatever reason, then you might see a more precipitous drop of oxygen going to the tissues from that low hemoglobin. So this is the reason why people have been hesitant to apply that hemoglobin of 7 cutoff to patients with cardiac disease because of this idea that they may not be able to compensate as much and we should transfuse sooner. But then on the flip side, we have to think about what the potential downsides are of that transfusion. And all of these things come into play here. One is, as the blood gets stored, the red cells themselves can become irreversibly deformed. We also have increased platelet aggregation, and of course the blood volume itself that can raise the risk of edema. For the platelet aggregation part, it's interesting, they've done studies where they test the blood immediately before and after a patient gets a transfusion, and they can measure the platelet aggregation, and they do find that there's more aggregation immediately after a blood transfusion. And then because a picture is worth 1,000 words here, I just wanted to include this photo from an electron microscopy picture of blood that has been stored for up to 5 days. And of course, this is what our healthy blood cells should look like. But we also see these deformed echinocytes, which you can imagine are going to predispose people to thrombosis if they already have diseased vessels. And that process just continues to worsen the longer the blood gets stored. You have a higher and higher percent of your cells that take on that irreversibly damaged shape. So they have since done then specific trials to try to get at the idea of whether cardiac disease should have a different threshold. And one was the FOCUS trial. This actually tested patients specifically who came in for a hip fracture, but who had either cardiac disease or other risk factors. And you can imagine just by their age alone, this is going to be a higher risk group for cardiac disease. And they were included if their hemoglobin fell under 10, and they were then randomized to either transfuse for a hemoglobin under 8 or under 10. And their hypothesis was that patients would do better if you transfuse at a hemoglobin under 10, if you have a higher threshold. So they first tested death or inability to walk 10 feet at 60 days, as well as these hard cardiac events. And in both cases, there was no difference. So in essence, the strategy of the lower hemoglobin kind of won in terms of you had equal outcomes using less resources to achieve it. So that was patients that had chronic disease. And so then where the reality trial comes in is related to patients with acute disease, acute coronary syndrome, and what is the safe threshold for them. So patients in this trial came in with either STEMI or NSTEMI, hemoglobin of 7 to 10, and they had to be not in shock and not actively bleeding at the time of enrollment. And they enrolled 668 patients, used this threshold comparison of 8 versus 10, followed them for 30 days. And this was designed as a non-inferiority trial for this combined outcome of CV death, MI stroke, or urgent revascularization. And here's what they found. So they had a 11% event rate for these combined events in the restrictive group. That was the hemoglobin less than 8 group, versus in the liberal group, 14% event rate when using a hemoglobin less than 10 to transfuse. So this did meet criteria for non-inferiority. That restrictive transfusion strategy was non-inferior. And then, this was not a superiority trial, so it did not show superiority, but just to give you an idea of the way the numbers trended for these different outcomes. So in all-cause mortality, that hemoglobin less than 8 threshold, the numbers were lower, fewer patients died. Also lower for recurrent MI, acute lung injury, and infection. And then the one outcome which was higher with that restrictive protocol was acute renal failure. So to summarize what we learned from this trial, using a transfusion threshold of hemoglobin less than 8 appears to be safe, non-inferior for patients even with acute coronary syndrome. And this is in line with previous trials that have found that same threshold to be safe for patients with chronic CAD. And we also know less than 7 to be safe for non-cardiac patients from the TRIC trial, and whether or not a hemoglobin threshold of 7 versus 8 would be appropriate for those cardiac patients as well is still an unanswered question, but we can at least feel more comfortable waiting until the hemoglobin is 8. So to go back to our question here, based off this trial, you could transfuse just patient A and not transfuse patient B yet, whose hemoglobin remains over 8. So this one relates to SGLT2 inhibitor use and heart failure. So I have another clinical question for you. Which patient would you start on an SGLT2 inhibitor? We have a 47-year-old female with non-ischemic cardiomyopathy, EF 30%. She's asymptomatic and euvolemic with no recent heart failure admissions. Or we have this 59-year-old, EF 40%, admitted twice in the past 6 months for heart failure, or both. Okay, so we have most patients that are saying they would start both patients on an SGLT2 inhibitor. So we'll go to the trial. So we have several trials now on this topic. Last year, I guess 2019, we had the DAPA-HF trial, which looked at dapagliflozin in this population. And then now more recently, we had the Emperor-Reduced trial, which looked at empagliflozin. So for the Emperor-Reduced design, we had patients with an EF less than 40 that were symptomatic. They had a high NT-BNP or hospitalization within the past year, a GFR over 20. And they enrolled 3,700 patients, randomized to empagliflozin or placebo, followed for a little over a year. And their primary outcome was a combination of CV death and heart failure hospitalization. And here's what they found. You can see both on the 0 to 100 axis, as well as this one that's blown up to 35. We can see this clear separation of the two groups with a decrease of events in the empagliflozin group. And this is highly significant with a hazard ratio of 0.75. And so that resulted in a number needed to treat of 19 patients, again, over a little over a year, about 16-month period. Now that change in outcomes was basically driven by the heart failure hospitalizations. When they looked at cardiovascular death, there was no significant difference, 10% versus 10.8%. And then this trial also studied renal outcomes, and they did find that although initially when you start the SGLT2 inhibitor, you see this small decline in GFR, after about a year, those curves cross and you start to see the renal protective effect. And to put this another way, if they look at how many patients had a significant sustained drop in GFR or had to start hemodialysis, it was 1.6% with the SGLT2 inhibitor versus about twice that with placebo. So that was also positive. And so to compare this with what we saw in the DAPA-HF trial, that trial was very similar design, EF less than 40, symptomatic. They had to have some evidence of volume overload at that time or in the recent past. And They again saw this highly significant difference with almost the exact same hazard ratio, 0.74 versus 0.75. And the one difference, though, was that the DAPA trial did show a decrease in death from any cause with this hazard ratio of 0.83 for an absolute risk reduction of about 2% over a slightly longer follow-up period. Both trials also broke down by subgroup diabetes status to see if that made any difference in the benefit. And so for the Emperor Reduced trial, we see the overall outcome that favored empagliflozin here. And then based on the diabetes status, there was no difference. Both groups saw a benefit, and that was the same for the DAPA-HF trial. Regardless of diabetes status, the patient saw benefit. So putting this together with the two trials of what we've learned, so this seems to be a class effect that SGLT2 inhibitors will decrease the rate of heart failure hospitalizations for patients with EF less than 40, and some evidence of volume overload, either by the BNP or recent admissions for heart failure exacerbation, with about a 25% relative risk reduction. And so the question that remains a little bit unanswered is whether or not mortality benefit in this group is also a class effect. So in our heart failure specific trials, only dapagliflozin showed a mortality benefit. However, in the initial trials that came out studying these drugs that were trials focused just on diabetic patients and not just on those with heart failure, we saw the opposite, that actually the DECLARE TIMI trial with dapagliflozin did not show a mortality decrease, whereas EMPA-REG with empagliflozin did show a 38% relative reduction in mortality. So, you know, it may be that it's simply based on how well the trial is powered, how long you follow up the patients. Perhaps we would have eventually seen a significant difference with empagliflozin, but at the moment we can only say that for sure based off the DAPA trial. And so going back to our question here, you know, there's been no change in the guidelines yet since these trials are so recent. But based off these trials, we really only know that we're going to see benefits in this patient B who has evidence of volume overload in recent admissions. And I think, you know, sometimes it's very tempting to extrapolate just based off of mechanism of how the medication works, which is pretty unclear, I think, to most people, exactly how the medication results in these benefits, particularly a mortality benefit. The diuretic effect of the medication is much more evident and clear in terms of how it works. So I do think we should not extrapolate all the way to patients who are not on a diuretic, remain euvolemic and asymptomatic. You know, those patients, we would probably see a very, very high number needed to treat to see that benefit. So until further testing, we should be applying it, though, to all of our patients with symptoms. And I think also if they're on a diuretic, you know, stopping the diuretic and swapping it out for the SGLT2 inhibitor also would be reasonable. Okay, so we're going to switch gears now to the topic of atrial fibrillation. And our question here is about a 60-year-old man with hypertension and obesity who was admitted with a new diagnosis of AFib with RVR. And he started on diltiazem, which achieves a heart rate control of less than 100 beats per minute while in AFib. He's then electrically cardioverted. And when he comes to your clinic, he remains in sinus rhythm with a heart rate of 65 on his diltiazem. He feels good. What would you recommend next? The choices here would be continue what he's on, refer him for ablation, or add an antiarrhythmic medication, for example, flecainide. So I think the results here reflect reality of our practice in AFib, which is that in many scenarios, there's not a clear right or wrong answer. And so there's a lot of style points in terms of how we manage these patients. Of course, you would always discuss with the patients well what they prefer, you know, but if they just come back to you and say whatever you think, there's still going to be a lot of difference, I think, in what the next step would be. So let's look at how this latest trial would affect that decision-making. This is the EAST-AF-NET-4 trial. This trial tested early rhythm control therapy in patients with AFib. And, you know, when I was deciding what trials to do, I was initially hesitant to go over this trial simply because this topic of AFib and rate versus rhythm control is such a muddy topic with a lot of trials that often seem to show very different results. But this is such a common thing that comes up, so I felt like it was worth taking a deeper dive into this topic and putting this trial in the context of what we know so far. So I want to take a step back, all the way back to 20 years ago when the Affirm trial was published. And for well over a decade, this was really the major randomized trial that we had to try to inform our decision-making on rate versus rhythm control. And the design of this trial, they included patients over 65 with risk factors for stroke or death who had Afib, and their main outcome was mortality. And the patients were randomized to just rate versus rhythm control strategy. How they did that was up to the providers. And you can see that they did have efficacy in having a separation here in how many patients maintained sinus rhythm at 5 years, about 1/3 versus 2/3. And these were their overall results. So this was essentially a neutral trial, negative trial with our p-value of 0.08. But you can see from the separation of the curves here, it looks like, if anything, perhaps rhythm control was associated with an increase in mortality as these curves started to separate at about 1.5 years and maintained that separation. But as I said, overall, this was a negative trial, and so it was felt that it was still kind of dealer's choice, the discussion with doctor and patient in terms of which strategy you went with. And I want to give a little more information on how they went about trying to control the rhythm in these patients, to explain why it was appropriate for this question to be re-asked and restudied. So the large majority of the patients had rhythm control done with medications, not with the procedure. And the most common medications that were used were these two, amiodarone and sotalol, in 2/3 of patients for amiodarone and 40% for sotalol. And these patients we generally use as being much farther down the list in terms of our first choice antiarrhythmics, at least for patients that don't have structural heart disease, just because of the better safety profile of some of the other options. Sotalol is associated with torsades. We usually have to admit people in the hospital to initiate that to make sure that it's safe. And amiodarone, as you all know, causes many long-term side effects. What we use more often these days is something like flecainide, which was used in a very small minority of patients at that time. And then another thing that I thought was interesting as I looked into the details of this trial was the beta blocker use. So as you probably would expect, more patients were on a beta blocker in the rate control arm. And what's interesting is that this trial, like I said, was published in 2002, so it was enrolling during the late 90s. And at that time, beta blocker use for systolic heart failure was not the standard of care. The first trial to come out to show mortality benefit with beta blockers was MERIT-HF in 1999. And there were about 25% of these patients in this trial who did have a low EF. And what I thought was extra interesting, actually, another 20% they had no echo data on at all. We didn't even know what their EF was. So it makes you wonder, is it possible that some of those patients in the rate control group has some mortality benefit from the higher beta blocker use? This is just me posing the question as a possibility. And in terms of ablation, which we use more often now, it was very rare in this trial. For reasons I don't really know, actually more patients in rate control had this procedure done when they crossed over if it was felt that the rate control option was failing, but a low number all around. And then lastly, very important, was that anticoagulation could be stopped for the protocol in the rhythm control group if they had been in normal sinus rhythm for 3 months. Whereas now all the guidelines tell us, even if that's your strategy and your hope to keep them in sinus rhythm, because we know that we often fail down the road, they should stay anticoagulated, assuming the CHADS-VASc would argue that they need anticoagulation. So given all those differences in how we practice then versus now, it was felt to be reasonable to pose this question again. So this is the design of the East AFNet trial. Patients had to have Afib that was diagnosed within the past year. So that was one other difference between this trial and others. But they wanted patients that had a recent diagnosis, with the idea that that's going to make it a higher likelihood of success that we could keep them in sinus rhythm. And they also had to have some other risk factors, so either over 75, prior stroke or TIA, or a couple of the other CHADS-VASc criteria that put them at higher risk. And they enrolled 2,800 patients, randomized them to rate versus rhythm control, which again was mostly at the discretion of their providers. Followed them for 5 years. And their primary endpoint was this combination of CV death, stroke, and hospitalization for heart failure or ACS. And this is how they chose to try to control the rhythm in the rhythm control group. So just to compare with what I showed you before, you can see that the first choice medication for most patients was flecainide. We had 20% as opposed to 2/3 that were on amiodarone to start. Others on dronedarone, which was not around at that time. And I was kind of surprised ablation wasn't used more often, but initially 8% had an ablation and ultimately up to 20% in that rhythm control group. And to compare that with the rate control, you can see that by 2 years, about 15% of those patients had crossed over to a rhythm control strategy, presumably because they still had symptoms even when rate controlled, and about 7% had ablation. And so here's how they did. So at the end of 2 years, about 80% of patients in the rhythm control arm were in sinus rhythm versus 60% in the rate control group. And looking at this, you can kind of see why it would be difficult to show benefit in some of these Afib trials, given that usually there only is a separation of about 20 to 30% in terms of how many patients are in sinus. So whatever difference in outcomes you're going to see, you have to see that within the 20 to 30% of people in your trial that are really achieving what you are trying to achieve. There's no difference in symptoms at 2 years. And as far as the primary outcome, the trial actually was stopped early though for improved outcomes in the rhythm control arm. There was 23% events versus 18% in the rate control versus rhythm control arms over, again, on average 5 years. And so that equates to about an absolute risk reduction of 1% per year. So how does this result compare to other trials? So I told you about Affirm, but we've also had in the past couple of years several other Afib trials. The one that was probably the longest awaited was the Cabana Trial in 2019. And the design here was a little different in terms of the two arms were ablation versus medical therapy, although often it was being tested against antiarrhythmics was the choice of strategy. And these patients were not necessarily a recent diagnosis. Many had been diagnosed in the past. And so accordingly, more of them had persistent Afib, which can be harder to control. But ultimately, you can see here, similar to the trial I just showed you, there was about a 20% difference in terms of the patients that remained in sinus rhythm in the ablation arm versus the control arm. So in a way, it does still test this question of whether or not trying harder to maintain sinus rhythm is going to result in lower events. And so this was their primary outcome. So they, a little bit different, looked at death, stroke, and then included serious bleeding in the primary outcome. And overall, this was felt to be a little bit disappointing, I think, by the cardiology community in that there was no significant difference. Our p-value was 0.3. Although numerically, events were a little bit lower in the catheter ablation arm. Now, as I kind of mentioned a little bit before, there was crossover in these arms. So in the ablation arm, there were 9% that never had an ablation. Either the patient or family just declined the procedure after randomization. And then 27% in the medical treatment arm actually crossed over to having an ablation. So, although typically with trials, we just look at the intention to treat analysis, they did also in this case look at an as treated or per protocol analysis. And the per protocol here it's similar to an as treated analysis, although not quite the same. But you can see that in this case, and this is looking actually just at mortality as the event rate, they did see a separation here with a significant p-value and a hazard ratio of 0.68. With a few percentage points difference in the mortality rate. And they saw the same thing when they looked at the primary outcome as a whole with this per protocol analysis. So you might argue, there's a reason we don't typically report these in published studies, that there may be something about the patients that cross over that predisposes them to have outcomes or not, such that that skews the data and is not really testing what we mean to test. But I thought it was worth looking at here because this is the reality of how we often treat AFib patients. You know, there's not one time point where you have to decide what you're going to do. You could try one strategy for a while, see what happens, and based off that, decide whether or not you want to change your strategy. So to me, I thought this does still kind of hint at that maintenance of sinus rhythm probably is better if we can find an effective and safe way to do it, with the caveat that overall this was a negative trial. And the last Afib trial I'm going to mention as background was the Castle HF trial from 2018. Again, this looked at ablation versus medical therapy. And what was unique of this one is that it just enrolled patients with a low EF. And again, although the actual arms were a little different, still testing this concept that we have about 20 to 30% or more patients who are in sinus rhythm in the ablation arm versus the medical arm. And in this trial, this was really the only AFib trial I'm aware of, randomized trial, where we really see a dramatic difference in outcomes in the two approaches. We see less death and hospitalization for heart failure with ablation than with medical therapy, be it antiarrhythmics or a rate control strategy. And this was highly significant. And that held up for both the the hospitalization piece as well as death from any cause was also lower. And so whether or not, I think there's a few options why we might have seen more benefit here. One is just the power. These heart failure patients are sicker. They're going to have more events overall. And you also see that if we kind of go back to the efficacy of the approaches, if we look at the pharmacologic group, only 20 to 30% maintain sinus rhythm in that group, as opposed to this other trial I showed you where even the control arm, 60% was still in sinus. So, these heart failure patients also are probably less likely to maintain sinus on their own. And so going to these extra lengths to try to accomplish that may be more needed and justified in these patients. So to try to put this all together, maintaining sinus rhythm seems like there's signals in these all these trials, except for that Affirm trial, of lower death, heart failure, hospitalizations, and stroke. And so when we actually have a patient in front of us and we need to decide what to do, there's two main things that we can ask ourselves. One is, what's the likelihood that the patient stays in sinus without us doing anything? And for example, in this East AF Net trial, where they looked at recently diagnosed patients, over 50% of those were still in sinus in the control arm. So maybe we don't have to, this is my opinion here, but maybe we don't have to jump straight to rhythm control option with the first occurrence of AFib. But if they prove to us that they're not going to stay in AFib, stay in sinus on their own, maybe that's when we want to think about these other approaches. And also that patients with heart failure are, on the flip side, less likely to maintain sinus on their own, less than 30% of them. So in that case, it may be more justified earlier on to take this more aggressive rhythm control approach. And second question being, what is the likelihood of the intervention to maintain sinus rhythm versus the risk of the intervention? So this is getting at the question of ablation versus these antiarrhythmic medications. Overall, antiarrhythmic drugs have about a 50% success rate to maintain sinus, versus ablation consistently has a higher success rate, with the exact percentages depending on who you study. And so younger patients, their risk versus benefit may favor ablation more, because they're going to have, if you put them on a drug, they're going to have many more years to stay on that drug, more time for side effects to happen. And on the flip side, ablation is going to be safer for them, as opposed to older patients, more friable tissue, higher bleeding risk, higher risk of more complications from that procedure itself. So just some things to think about. So I'm curious to ask this question again and just see, let me switch my slide. Just to see if there's any difference in what people would answer. The same question, and I guess I phrased it a little differently here. What strategy would you choose if this were you? Because of course, there's going to be still a lot of patient discussion and patient preference. But what would you choose for yourself in this situation? So it looks like kind of a similar breakdown to what we had before. Personally, I think I would probably go with option A as well, if this is the first occurrence and I'm otherwise healthy. But I think if it recurs, within the next year or two, then I would probably vote for the ablation, have the higher chance of long-term success from that one-time procedure as opposed to taking medication for the long term. But overall, I do think maintaining sinus rhythm probably is safer, and it's just a matter of who is the right person where it's justified going to those lengths to try to do that. This is a 70-year-old male with Afib on apixaban who presents with an anterior STEMI. The left heart cath shows a mid-LAD lesion, which is stented without complications. And how would you treat? Triple therapy for 6 months, so that meaning aspirin, P2Y12 inhibitor, and anticoagulation for 6 months, and then stop the aspirin, versus 1 month and stop the aspirin, or just until discharge or about a week and then stop aspirin. So let's look at the data. This gets at the Augustus Trial, which tested the antithrombotic therapy after ACS or PCI and AFib. And we did have other trials before this, which looked at the concept of double versus triple therapy, meaning to continue aspirin or not in this setting. And those were, we had a trial with rivaroxaban in 2016 and one with dabigatran in 2017. The problem with those trials, though, was that they weren't really comparing apples to apples. Both of those trials, in their triple therapy arm, they had warfarin and the P2Y12 inhibitor and aspirin. And then in the double therapy arm, they had the NOAC and the P2Y12 inhibitor and no aspirin. So, these trials were really designed to show benefits of the NOAC over warfarin as one strategy. And so teasing out were differences in events driven by that difference versus the aspirin or not was the problem with these trials. So the Augustus trial was the first one to really compare apples to apples with this question of how long to continue the aspirin. So they included patients with AFib who were anticoagulated, and then they had a stent or acute coronary syndrome within 14 days. They enrolled 4,600 patients and randomized them to either get aspirin or placebo in addition to their other two medications. Followed them for 6 months. And their primary outcome was bleeding with the secondary outcome of death, hospitalization, or ischemic events. And here's what the primary outcome showed. For major bleeding or clinically relevant non-major bleeding, in some ways, unsurprisingly, there was more bleeding in the aspirin group. But I do also think it's worth noting the magnitude of the difference, 16% versus 9%. So overall, over just 6 months, we had a 7% absolute risk reduction in clinically relevant bleeding, which I think, we kind of think of aspirin as, not as big of a gun as our other medications, antiplatelets and anticoagulants. And so I think we often kind of minimize the bleeding risk associated with aspirin. But at least in this particular group of patients that are probably higher risk for bleeding because of their comorbidities, as well as their other medications, we really did see a pretty dramatic difference in the bleeding rate. And then to look at the secondary outcomes, death and ischemic events, aspirin was about 6.5% of patients had an event over 6 months versus a little over 7% with placebo, although this was not statistically different. And so looking at this data in combination with those other two trials, even with the caveats that I told you about those previous two trials, the group without aspirin, we saw fairly consistently a 6 to 10% decrease in bleeding events in the group without aspirin. And in terms of MI, we saw about a 0.5 to 0.7% increase in the risk of MI. So in terms of absolute events, you can see it's a very small small group that has MI prevented in exchange for a much larger group of patients that are going to have bleeding. And so to go back to our question here, the practice that we're using now is really to minimize that triple therapy. So our practice is to just do aspirin until discharge, and then at that time stop the aspirin, just maintain them on the anticoagulant and the P2Y12 inhibitor. And this change in practice has actually, the guidelines have caught up with this, where we see in the American guidelines, they recommend in patients with AFib who've undergone PCI or ACS, that double therapy with the P2Y12 and a NOAC is reasonable. And the European guidelines get a little more specific. After uncomplicated elective PCI, early cessation within a week of aspirin should be considered if the risk of stent thrombosis is low or if concerns about bleeding prevail. And in the majority of our patients, the risk of stent thrombosis with our new stents is low, with some exceptions being if patient had a complicated anatomy that required stenting, or they have a history of in-stent restenosis or left main stent.